Hello everyone, and thank you for the opportunity from ARM to present today our two next generation platform technologies to enhance current cell therapies. I have the challenge of going over two of these, so I'll just skip over them relatively quickly, but you can see that it's attempting to tackle a lot of the problems that you all know about here through two different mechanisms. I'm going to speak about Omni-CAR, our modular platform technology from Penn and Oxford, and our Cell Prime technology, which can be dropped into any program being undertaken right now. Omni-CAR is a modular universal immune receptor system that we've licensed from Penn, incorporating technology also from Oxford. There's a handful of modular systems around, but this is the only one that's covalent and has a number of advantages that I will speak about in a minute. So you'd be well aware with these systems, it separates the signalling domain from the targeting domain. So without the binder, these cells are viable but inert until you add a separate targeting ligand and the tag and the anti-tag come together like two bits of Velcro to form a fully armed CAR cell. And what makes this unique and a genuine platform is that this looks like an antibody in this illustration, but it doesn't need to be. It could be an SCFV, it could be an aptamer, it could be a peptide, it can even be a small molecule. Whatever binds to an antigen, we can tag it, and we can tag it anywhere to control the immune synapse as well. We can also work with any immune cell. We heard some interesting discussions this morning already on various cell types. We're not cell type zealots. We're not cell type developers. We can work with any cell. If it can be improved through modularity and multivalence and redirection, then that is where we come in. So just to highlight some of the features here, obviously with current generation CAR T therapies, there's no post-infusion control. It is what it is. With this, by controlling the amount of binder you get, we see a dose response curve that you would normally expect to see with a small molecule or a biologic. We can switch it on and switch it off. We all know that there's suicide switches being developed to switch off these therapies if they need to. Problem is that terminates the entire therapy, but by just simply ceasing administration of the binder, this therapy switches itself off but remains viable and can be reactivated by subsequent administration of the binder. So it's good for safety, but also this metronomic stimulation also improves the persistence of the cell therapy. I'll show you some data in a minute showing how through directing, you can direct from one target to another by just switching out the binder, and also how we can multi-arm these to create a truly multivalent product. And I should mention up front, we also have a number of orthogonal systems here so that we can have built-in logic gating here. So this is a co-culture of GBM cells, one cell population overexpressing HER2, the other EGFRV3, and we treated it with an Omni-CAR EGFRV3 cell, and you can see straight away it is hitting those EGFRV cells and leaving the HER2 cells alone. And at 20 hours, which is enough time for some progeny cells which are unarmed, because when these cells replicate, they are unarmed, and that's what enables the control. We drop in a HER2 binder, there are no new cells, and you can see what happens here is it stops killing the EGFRV3 cells and immediately starts killing the HER2 positive cells. So again, for the first time, we believe being able to show redirection with a single cell product from one antigen to another. Some have asked also, well, how long do these last? Well, we've got data going out much longer than this, but at very least 3 weeks. You can see it's not doing anything until we tell it to, and you can see that the tumour's getting quite large at this stage when we administer the binder subsequently at day 21, and you get, it's showing it can be armed at will, and when you arm it at will, you get immediate cytotoxicity. Some have also asked, well, is there a compromise with potency when you modularize these systems? And because this is covalent, it is not. On the left, you can see a standard HER2 CAR, a best-in-class one from Peter Mack, and on the right, the equivalent with ours, a modular system. And you can see the red tumour cells, as soon as they lyse, become green, and you can see there the same ET ratios and the same time frame. It's at least as potent and arguably more potent. So no compromise there on potency when you modularize it. And where do we see this going? So we've got we've got 3 programs. AML, we're looking at CD33 and CLL1, a HER2 program, and also GBM. But we see a world in the not too distant future when patients are able to have their tumours biopsied and characterised, which of course happens already, yields a number of different targets. There's 33 in AML alone, but where we can pull binders off the shelf and put them, plug them straight into an Omni-CAR cell. Doesn't need to be a T cell, it can be an NK cell, a macrophage, or whatever it might be. And a patient is getting a controllable therapy that is bespoke for their antigen profile in their tumours. And if there does happen to be any residual tumour, or if the tumour occurs, you don't necessarily need to give another cell therapy. You can cycle back and give that binder. And anyone here who happens to be developing a binder, what's novel about this system is we can tag it and pull it into the ecosystem. Similarly with novel cell types, there are advantages with one cell type over another. We can tag that and pull that into the ecosystem as well. Also some practical advantages with this as well. If you want to do this with current approaches, obviously you need a number of different CAR constructs with a number of manufacturing runs. It's obviously not viable. With Omni-CAR, you do the hard work once. You have that master cell approach, and all of the binders can be administered without any lag. For those developing off-the-shelf cells, this is very attractive to them because they realise that cell is part of the master IND, and you can drop all the binders in that under that umbrella. So I'll switch gears now and speak about Cell Prime, which is our cell therapy enhancement. This one is a small molecule cell therapy enhancement, and it comes in 2 forms. One, Cell Prime M in the manufacturing step, Cell Prime A is for adjuvant, which is administered to the patient. It works via very different mechanisms in both these settings. And I'll speak about Cell Prime M first, which produces a more youthful, more desirable cell phenotype. It is ready for the clinic. We fully own the IP, and it is ready for collaboration right now with other parties. So it's a small molecule that's dropped into the manufacturing process in a 24-hour step. We see changes in gene expression within 15 minutes, very, very rapid. So it doesn't take an additional 24 hours. It can be incorporated into current manufacturing protocols. And what we see, this learned audience knows all about cell maturation, but obviously, current cell therapies tend to have too many of these effector types, which are obviously very potent, but die off before the job's finished. And those patients who tend to have the better responses tend to have more, a bit of a balance there, typically central memory T cells. And what's special about Cell Prime M is by dropping it into that manufacturing process, it shifts the phenotype towards that central memory phenotype. And it doesn't just halt the maturation of these cells, it actually plays the tape backwards. So it can take a more mature cell and revert it to this central memory phenotype. In fact, there's 50% more central memory cells using this approach. By taking a standard CAR T that is in a model that's resistant to these CAR Ts, it doubles the performance of these. And you might wonder, well, once it's in vivo, does it revert back? This is a couple of weeks later through cheek bleeds, and you can see both the CD8s and the CD4s. Both populations have a more desirable population of cells, sustained increase in central memory cells and a sustained decrease in effectors. So this phenomenon looks to persist in vivo. Also doubles the proportion of helper cells and also significantly increases the proportion of chemokine receptors, which are obviously great for trafficking. So that's Cell Prime M used in the manufacturing scenario. Oh, and this is some fresh data that recapitulate what I've already spoken to here. You can see some untreated mice there using a control CAR T. Again, this is our HER2 models, and by doing nothing else but manufacturing those by dropping in Cell Prime M, you can see a marked difference there in the performance of that particular CAR T without any changes to the CAR T itself. So that's very, very easy to incorporate into Cell Prime M, but it can also be incorporated as an adjuvant alongside cellular therapies. And this is very important for boosting the performance of these without any other alterations to the CAR-T. Can improve survival, importantly reduces problematic Tregs by 2/3, can dramatically increase expansion of these cells in vivo. This poor photographer's trying to get my good side. I don't have one, mate. It can also boost the performance by up to 9-fold, and the ability to penetrate a very hostile TME as well. And when it's used with cell prime M, it's even better. So again, this is the syngeneic model I showed you earlier that's basically resistant to CAR-T, and we get improved performance by using cell prime A, but when you use cell prime A in combination with cells that had been manufactured with cell prime M, that's when you see these amazing synergistic benefits. And this was the only, the far right there, the only one with palpable tumour. In Australia, where these experiments have been carried out, there are ethical limitations on how long you can take these experiments, but basically CAR-T alone had no improvement on survival, and there was a marked improvement in survival just by using cell prime A alone. Again, I said it reduced Tregs by 2/3, which is important in that it can be used with even in vivo approaches or other approaches where, wherever Tregs are going to be problematic. Again, increasing expansion in vivo with the cytotoxic cells up to 9-fold, which is amazing, and helper cells 6-fold. And do these cells then get to where they need to get and penetrate that very hostile TME? And you can see there 3-fold and 4-fold respectively for helper cells and cytotoxic T cells. So I've just described a number of different, 2 different technology platforms we have. Just as a reminder, OmniCAR is about modularising these cell therapies in order to enable post-infusion control, to enable redirection and genuine multivalence. Cell prime M improves the performance of the cell itself, a more youthful cell that kills for longer and lasts for longer, and it can be used with current generation cells as well, and cell prime A can be used with all of it, especially those programs tackling solid tumours. So I think I managed to cover off everything within your allotted time frame, and happy to take any questions. Otherwise, I'll hand over to the next speaker. No. Many thanks. I'm hanging around, so feel free to approach me if you have any questions. Many thanks.